Pneumococcal diseases is an important cause of morbidity and mortality in senior adults worldwide. To guide us about the prevention of pneumococcal disease, we have our next speaker with us, Dr. Professor Debmalya Sanyal, eminent medical consultant attached to RN Hospital, Kolkata. And to chair this particular session, I'd like to invite Dr. Somnath Noshkar, who is also an assistant professor of SSKM Hospital, and Dr. Sanjay Kesha, one of the founder member of HDS. And we have another chairperson with us, one of the senior most pulmonologist and medical consultant, Dr. Shubir De. I would like to request our chairperson to please take the seat and introduce our speaker.
Okay, very good afternoon to all. As we know that we are very acquainted with the macro and microvascular complications of diabetes, but apart from that, there are many other things like infectious disease and diabetes shares a vicious cycle. So one worsens the other. So, and with age, there is a decrease in immunity, immunosenescence, there are lots of things. And to discuss all these things, we have a very eminent speaker, Dr. Debmalya Sanyal, who is my guide also in a way. So, sir, please start your deliberation.
Thank you. Thank you for the invitation, and I would like to thank the organizing committee, including Sanjay for the invitation. So we'll be discussing diabetes and infection, and especially with regards to pneumococcal disease and pneumococcal vaccination. So we are all aware this is 77 million, but the Lancet publication in to this year suggested that now we have 100 million of diabetes and 135 million of pre-diabetes in India. Unfortunately, 50% of the patients are unaware whether they have diabetes or not. Even during hospitalization, about 30 to 40% of all hospitalized subjects have diabetes. And it is associated with threefold risk of myocardial infarction and stroke, and again, threefold increase of kidney disease as well. Very important that there is a vicious cycle of diabetes and infection. So if there is poor glycemic control, there is immunocompromised state, and that leads to higher increased chances of infection. And infection also begets hyperglycemia as well. So it's like a vicious cycle as well. And again, because of frequent infection in diabetes subjects, there is higher use of antibiotics, and that would also lead to antibiotic resistance as well. So that is also something of concern. So why there is more chance of infection? One is you have the decreased neutrophilic chemotaxis, phagocytosis, granulocyte adherence, intracellular killing of bacteria is decreased, complement fixation is decreased, as well as the final superoxide production is decreased, all contributing to increased risk of infection as well. Now, why there is worsening of glycemic control with infection? There is counter-regulatory hormones are released like catecholamines, glucagon, and growth hormone, which increases glycogenolysis and gluconeogenesis, which is also contributed by TNF-alpha, interleukin-1, and IL-6, which are the cytokines. And all of these also cause increase in insulin resistance as well. So we have this cycle of uncontrolled hyperglycemia leading to decreased immune function, and that leads to increased susceptibility to infection, and this also triggers further hyperglycemia as well. So with regards to pneumococcal infection and diabetes. So diabetes is a well-known risk factor, and there is a nasopharyngeal colonization is higher in diabetes subjects, and they have a higher risk of severe respiratory tract infection compared to non-diabetes. And again, in diabetes subject, invasive pneumococcal disease like pneumococcal pneumonia, pneumococcal meningitis, and bacteremia, which are invasive pneumococcal disease, are nearly 3 to 4-fold higher compared to a non-diabetes subjects. And also, as I was mentioning, poor glycemic control is associated with higher risk of community-acquired pneumonia as well as invasive pneumococcal disease. So, along with influenza, you have pneumonia, which actually leads to further risk, 3 times higher risk of dying from pneumonia or from influenza as well. And the case fatality rate because of pneumonia in diabetes ranges from 20 to 35%. So, in a diabetes subject, especially who are elderly, more than 65, those who have underlying cardiovascular and renal disease, which will be about 50%. If you take both into account, it will become the risk of infection and morbidity and mortality increases significantly. Very importantly, age, especially after 60 or 65, there is a significant risk of invasive pneumococcal disease in elderly, in diabetes subjects as well. So in diabetes, we have decreased inflammatory cytokines, decreased T lymphocyte function, as well as antioxidant status, along with the cardiovascular and renal compromised state, which leads to poor vascularization. And all of these, along with poor antibody response and a poor cell-mediated immunity, predisposed to pneumonia. And we also have a huge, staggering number of elderly, nearly 12.1 million elderly with type 2 diabetes as well, and which is supposed to increase significantly, double in the next 15-20 years. So if we see that one of the most important comorbid factors which was associated with high risk of mortality in hospital admitted patients with pneumonia, pneumococcal pneumonia, was basically diabetes, and this was more importantly seen in patients who were elderly and who had a lower BMI as well. So this emphasizes the critical issue in diabetes patients with regards to prevention of pneumococcal disease. And again, if you see in Indian perspective, if we have the case fatalities 30% in patients who are more than 50 years, and again Streptococcus pneumoniae is the most common organism in causing community-acquired pneumonia and more common in patients with comorbidities as well. So the whole concept of pneumococcal vaccination and prevention is that it reduces the chance of one is becoming infected with pneumococcal bacteria, and also it improves survival, reduces the chance of hospitalization and development of invasive pneumococcal disease, and also respiratory failure. And the PCV13 has also been approved to prevent pneumonia and invasive pneumococcal disease by 13 serotypes. So this is the development of the vaccine schedule by different societies. And we have the ADA guidelines advocating pneumococcal vaccination because this has a significant reduction in morbidity and mortality with pneumococcal disease in type 2 diabetes, and the goal should be to immunize all diabetes patients, particularly with complicating factors like elderly, CKD, cardiovascular disease, and also those who have had a recent history of hospitalization. And this would reduce the risk of complications as well as recurrent hospitalization as well. And very important, there is a sufficient evidence that diabetes subjects can have an appropriate, robust humoral response to vaccination as well. If we have other societies as well, the Canadian Diabetes Association, all advocate at least one lifetime immunization with pneumococcal vaccination and annual influenza vaccination. You have the American College of Physicians, where also they recommend apart from age and chronic illness, diabetes mellitus is important, as is the World Health Organization guidelines. Now, this is our own RSSDI guidelines, the Research Society for Study of Diabetes in India. You have the recommendations are that all diabetes should be educated about administering at least one pneumococcal and influenza vaccine yearly. Pneumococcal vaccine, 2 doses, 2 pneumococcal vaccines are available, the PCV13 and the PPSV23. And what we know is that the secondary immune response, especially after PCV13 use, is higher, where if it is only with the 23 valent, it's actually less. So it is recommended that first we give the PCV13 because we do not have a mass child immunization with pneumococcal vaccination in our population. That's why the Western population may only give the PCV23, but in our population, PCV13 is very important because we need to include all the strains. And above 50, we need to have the first dose. 1 year later, we can have the subsequent dose of 23 and repeat that after 5 years. So, especially the PCV13 is available for vaccination in older adults and must be considered for any subject more than 50 years of age. So, what should be the vaccination schedule, which is very important for providing maximum effectiveness for vaccine preventable disease? So, patients who do not have any prior pneumococcal vaccination, you first give a PCV13, then the 23 valent after 1 year. It can be given especially in immunocompromised subjects like CKD as well as cardiovascular disease after 8 weeks as well. After the 13 valent, we can give the 23 valent. And those who have already previously received the 23 valent, we need to wait for 1 year, then we give the PCV13, and subsequently after 5 years, we can repeat. Again, there can be co-administration of influenza as well as PCV13 as well. With regards to COVID vaccine, which is now not very commonly used, there needs to be a gap of about 14 days with regards to any other vaccine. So, if we combine the influenza vaccine with PCV13, there is no long-term impact on circulating functional antibody as measured 5 years later. The immune response, even in patients more than 50 years, is non-inferior when they are given alone. A combination vaccine which may be more convenient for the patient as well, but we must remember that the site has to be separate, not the similar site. So, the impact of adult immunization, one is individual protection against vaccine preventable disease, again reducing the comorbidities and severity of pneumonia like invasive pneumococcal disease, and there can be also improvement in mortality and hospital stay as well as there is reduced risk of developing antimicrobial resistance by slowing the spread of resistant pneumococcal serotypes like 19A and averting the disease occurrence. And therefore, the use of antibiotics can be avoided. So, dual vaccination with pneumonia and influenza is effective and can have a prolonged protection in elderly as well as in patients, type 2 diabetes patients with chronic complications as well. So, whether we deal with vaccination or respiratory patients or not, we need to be aware, we need to make our patients aware with regards to the access of vaccination. We need to recommend the vaccination as well as, if possible, tell them to administer the vaccine and document vaccination because that's very important as well. So, finally, diabetes, we are all aware, is one of the states where there is higher risk of infection as well as infection begets hyperglycemia as well. So, that's a vicious cycle and that leads to higher morbidity and mortality. It is true similarly for pneumococcal disease as well, where there is higher risk of invasive pneumococcal disease as well as mortality in diabetes, especially in elderly with cardiovascular disease and renal disease, and because of their compromised immune function. And hospitalization and death actually can be decreased by use of pneumococcal vaccination, as can be decreased the antibiotic resistance as well. So we need to educate all caregivers and all our diabetes patient subjects with regards to administration of at least 1 dose of pneumococcal vaccine and yearly influenza vaccination. Thank you very much. Thank you for a patient hearing.
Nice deliberation by Professor Debmalya Sanyal. Now we can have one or two questions from the audience. After that, I will have some comments.
Any question from the audience?
There are so many questions I'm having myself. Yes. Please come to the mic.
So then what you will do?
So again, in those patients, there is no recommendation that we should be withholding vaccination, because they are actually more susceptible with regards to development of pneumococcal disease as well.
Yeah.
Well, even if there is a chance of some diminished response in those patients, we can give the subsequent vaccination. First, we start with PCV13, then after we can go for 23. After 8 weeks, as you can say, we can decrease the gap from 1 year to 8 weeks, and then we can subsequently revaccinate after 5 years. There is even the option of going for the third time revaccination as well.
Some patients, when they are on chemotherapy or the cancer, after the completion of chemotherapy or surgery, should they be given?
Yes, absolutely.
This, and influenza vaccine also?
Yes.
It doesn't interfere.
Please come. After that, I'll take just 2 or 3 minutes to convey some important messages.
Sir, I'm Dr. Rajarshi Sengupta, previously with the Command Hospital, retired from the Indian Army. One question that I have is, an 82-year-old lady who is not otherwise having any immunodeficiency with a complaint of cough, would you like to go in for vaccination? If yes, why? And if no, then why, sir?
Well, with regards to any acute episode, I would wait for the acute episode to resolve at least. But subsequently, obviously, we would like to go for a vaccination in an elderly, more so because the risk of invasive pneumococcal disease in elderly, as I have shown in my slide, that the risk increases significantly, and it increases more with age, after the age of 65. So the risk of dying, mortality and development of bacteremia, pneumococcal pneumonia is much higher in an elderly than in a young population. So it's always more important, even if you can't vaccinate your young people, at least if you want to, because of cost purposes, you must go for the target population. Elderly is always target population. And you can imagine a patient who is admitted with sepsis, the chances of survival in elderly decreases, and the cost in ICU admission is also significantly decreased. And also I showed you in one of the slides that ICU mortality is one of the highest, especially with pneumococcal disease and those who have concomitant diabetes as well. So definitely.
Good afternoon. I have a small question. That in case of the different rheumatological disorders, the use of the biologicals are upgrowing, and we often just screen these patients for the tuberculosis and all the major infectious disease prior using this. But do you routinely recommend the pneumococcal and the influenza vaccines prior using any of the biologicals in this group of patients?
So if you see, even with regards to transplant protocol, they routinely recommend use of vaccination prior to any transplant or these procedures or these medications as well. So it is obviously very important to recommend these vaccination, including, I didn't go into discussion, like in patients who are splenectomized, in patients who have HIV, even in those patients, they should be vaccinated definitely.
Yes.
I'm asking about the specific situation of the using biologicals in the rheumatological conditions.
So I won't be able to, because I frequently do not use biologicals associated with rheumatological, so I wouldn't be able to make a comment on that.
Biologics has been used in cases of asthma, not in pneumonia. I just want to add 2 or 3 things. Now, prevention is better than cure, we all know. William Osler, one of the fathers of medicine, often said that pneumonia is a friend of the aged. Now here, according to Shakespeare, we have 7 stages in our life. So ultimately, when we go down to that stage over 65, we go back to our first two stages. One thing which we should have, and you showed, that slide went very rapidly, that is a adult vaccination card for adults. We are working on it. I would request diabetologists, physicians, nephrologists and others to make their own cards and write to the government of India so that we can sit in and formulate the policy. Secondly, what we did from our chess society in 13 January 2019, after a 10-year thorough survey of different evidences, we prescribed the dosages of influenza vaccine for India, 30° north above and 30° north below. In West Bengal, we had a habit of giving in September, but they found that 70% of the cases due to influenza were occurring just after the onset of the monsoons. So in our West Bengal, it is suggested that we give the quadrivalent vaccine just before the onset of monsoons. West Bengal, Kolkata and Bombay, they do fall in the same line. But over there in Srinagar and Chennai, over there it is given in the winter before in September. But this year, since we had a late monsoon, if we give the vaccine now, in late September or in October, it will be most efficient. Thank you very much. I shall not waste any time. The chapter is very big.
Thank you. And I hope we are more proactive. Even myself, I was not that proactive a few years back. But we need to be more proactive because we can do a huge benefit with our elderly patients and patients with CKD, CLD, cardiovascular disease in prevention, and that will be cost effective as well. If you look at the IT cost for any person, it's very high. So if you can prevent invasive disease, that's a big benefit.
See the vaccination card in US.
Thank you.
Thank you.
Thank you, sir. Thank you, Speaker. Thank you, Chairperson. It's time to felicitate our speaker. I would like to request our Chairperson to please felicitate our speaker.